Hello, welcome everyone. Welcome to Medicine Grand Rounds. The QR code is on the screen for those of you wanting CME mocks, so I'll remind you of that. But today I have the pleasure of introducing our Kroc visiting professor. It's Professor Georg Schett, who is a professor and head of immunology and rheumatology, as well as the vice president of research at Friedrich Alexander University in Erlangen, Nuremberg, Germany. In addition to being a member of the National Academy of Sciences of Germany, he has numerous other honors and awards. He has published well over 1,000 manuscripts in peer-reviewed journals, very high impact work, as you will learn today, over 800 invited seminars and conference talks. He truly is a leader in rheumatology. His work has helped us understand the pathophysiology of rheumatoid arthritis and lupus. And really importantly, he has been an innovator in developing cutting-edge therapies, including bispecific T-cell engagers and CAR T-cell therapy for a lot of our rheumatologic diseases. And I think he's going to share with you today some of that cutting-edge therapy development. So Professor Schett, please, welcome.
Can you hear me? Yes. So many thanks for the invitation. Thank you for the nice words, Christine, and thank you also, Brian, for showing me around. It's my second time at the campus. I'm very happy to be here, and I'm always very impressed about this modern campus and also the science and the clinical achievements which are done here. So congrats at the beginning. And we also work together since many years in understanding better rheumatoid arthritis, and also recently in developing new therapies for autoimmune diseases. And I will share you a little bit the story of cellular therapy in autoimmune disease. As you know, cellular therapy has been used 20 years ago with autologous stem cell transplantation, but it has been a little bit abandoned because of safety issues. And now gene editing and cell editing has been actually introduced in oncology, and this actually spread now very rapidly to autoimmune disease. And I start this talk usually with this young lady. She was the first being treated outside the oncology field with CAR T cells. She has been 20 years old when she received the CAR T cells in 2021, and is now 4 years in complete remission. And she's very lucky, and I think her case also led to I would say, to a appreciation of the possibility that you can change the life of a patient with autoimmune disease by CAR T-cell therapy. Now I start with Renoir. Renoir had rheumatoid arthritis, as you can easily see when you look at his hands, and at this time he had only aspirin available as an anti-inflammatory drug, and aspirin to some extent improved his symptoms, but it was not safe. As you may know, in the anti-inflammatory doses, aspirin is quite toxic, and it did not interfere with the disease process. All conditions which are absolutely required now for a medication treating autoimmune disease, and you can easily see that it really didn't interfere with the disease process when you look at his hands, and it did by no means cure the disease. And that's, of course, our wish as doctors, that we cure a disease and not just prolong it and suppress it to some extent. Now, a real change came with the introduction of monoclonal antibody therapy targeting several different cytokines. And I think at the time, the idea came that monoclonal antibodies could be used in the treatment of inflammatory disease. Many people said, well, that's never work, right? And in fact, there was a big revolution. Now we are used to have injectable drug therapies and targeted drug therapies in many different inflammatory diseases. And we learned, I think, very interesting lessons that, where is actually the pointer? Anyway, we learned very interesting lessons that there are two master pillars of inflammation. And when you cut these master pillars, so to say, then this wheel of inflammation cracks down, and the process is done. And that actually was quite interesting, because many people thought that inflammatory mediators are very redundant. There are hundreds of inflammatory mediators, and when you take out one, nothing will happen. But that was completely wrong, right? I mean, there was a shift in the dogma that there are key crucial cytokines in certain diseases, and it also led to a re-understanding of inflammatory diseases, particularly also rheumatic diseases, but also now other inflammatory diseases, that you go away from a textbook idea, and here are two trees. The upper tree is actually a textbook-like tree of inflammatory diseases, which is based on organ involvement, and the lower tree is actually a cytokine-based tree of inflammatory diseases, and you can see that it's not matching 100%. And it shows, like in oncology, that mechanisms for inflammation are critical because they have similar, same targeting approaches. I think that's one of the biggest changes, I think I would say, in inflammatory medicine in the last 10 years. Now, we are still in a way in a treatment, in a traditional scenario of treatment. What we do is actually we suppress the disease by introducing a drug therapy and keeping it for probably lifelong, at least many years. And what we do is we suppress the disease process, as you see here. Sometimes you have little flares, but definitely it's better than before. But this means that we never get rid of the disease. This disease is still there, and we just suppress it. And what our wish is, of course, and we always should have wishes in medicine to get better, is that we have a short-term approach therapy, which is indicated here in blue. And this short-term approach actually turns down disease activity and truly leads to absence of a disease, kind of a reset of the immune system, that you have no treatment anymore, and the disease is indeed gone. So now, why is this important? Now, inflammatory, especially systemic inflammatory disease like lupus here or dermatomyositis are very severe diseases. The treatment has improved substantially, not lastly because of the introduction of monoclonal antibodies and also better immunosuppressive drugs. However, there is still an increased mortality in lupus, due to organ failure, due to infection, due to continuous immunosuppression, and there are also some diseases which actually have a survival curve like a cancer patient, and a typical example is MDA5 related dermatomyositis, which has a very poor prognosis due to rapid progressive interstitial lung disease. And this also pertains to others. Here, two more examples. GPA, it can be very severe, very rapid, and especially life-threatening due to granulomatosis in the lungs and rapid kidney failure, and also systemic sclerosis with a progressive fibrosis of the lung, interstitial lung disease, and heart disease is a very bad disease with an increased mortality and limited treatment options. So in a way, we still are not perfect in these diseases. We can treat them better, but we encounter patients who still die from these diseases. And the root of all these diseases are autoantibodies. Autoantibodies, and this here is actually a center for autoantibody research in rheumatoid arthritis, defining the pre-disease in rheumatoid arthritis. And this is also found in other diseases. Here is an example from lupus. You can see here, each line is an autoantibody entity, and you can see that these autoantibodies develop and increase in titer in the pre-phase of the disease. The vertical line is when the patient comes to the doctor because of symptoms related to lupus, like rash or like arthritis or nephritis. And but in this case, when the patient is already clinically manifest, the autoimmune response is built up, and that's based on the fact that there are already autoimmune B cells driving the disease over years, and you come into the disease with already a mature immune response against self. Now, it has been logic that B cell targeting is actually very interesting in these diseases. And B cell targeting is, when you look back, most of the B cell targeting so far has been done with rituximab, which is a chimeric anti-CD20 antibody, which is infused every 6 months. And surprisingly, this did not really work well in all the diseases. It has been improved in rheumatoid. It has been improved in granulomatosis with polyangiitis. It has been improved in epidermolysis bullosa, pemphigus, but it didn't work, for instance, in lupus. And this is one example where you can see two superimposing lines. One shows actually the disease activity of lupus here, and the other one shows the flare-free survival. And basically, there's no difference between rituximab and placebo. And that has been extremely disappointing. And I always say rituximab is probably the only drug which is still used in lupus despite negative clinical trial data and no approval, because many observational studies supported the use of rituximab in lupus. So the reason for these negative trials are, I think there's probably not one reason. One is probably that the glucocorticoid effect, right? Because glucocorticoids are used in both arms and also work in lupus, of course. And another one is probably that rituximab has intrinsic properties which do not allow to have a deep remission. And this is shown here, an example from transplant medicine. And I think that's an eye-opening experiment, a very simple experiment. What the transplant surgeons did, they actually treated the patient with rituximab before the kidney transplantation to avoid humoral graft rejection. And then when they implanted the kidney, they explanted the abdominal lymph node and looked in the lymph node whether there are B cells. And in fact, what was very surprising, this lymph node was full of B cells. You can see that the B cell, the rituximab treated patient had almost as many B cells in the lymph node as the non-rituximab exposed patients, despite a complete peripheral B cell depletion. And that shows very nicely that rituximab is actually not depleting in the tissue. So basically, that's an important feature and disadvantage of this drug. And this is also shown, for instance, in several other studies. Here is one, which is in rheumatoid arthritis patients. So the rheumatologist did a joint biopsy. They checked for the immunostained B cells, which you can see here in brown. And in fact, in many patients, there were a lot of B cells despite rituximab exposure. And rituximab was still depleting the B cells in the peripheral blood very well. So it shows that it's not so easy actually to deplete B cell in target organs and in secondary lymphatic organs like in the lymph nodes. So this situation is unacceptable for a cancer patient, right? Because when you have a lymphoma or leukemia and you have one malignant B cell left, you reconstitute the whole body and you ultimately die. So in hemato-oncology, actually, there has been a strong push also because of failures of rituximab treatment to improve actually B cell depleting strategies. One way is to build actually better antibodies with higher affinity and glycoengineered antibodies, which allow a better depletion of B cells, which is obinutuzumab, for instance, which is also now used in autoimmune disease. Another way is the so-called T cell engagers. They actually bring the T cells to the B cell and use the effector function of the T cell to kill the B cell. And they are widely used now in oncology and have also been introduced in autoimmune diseases. And I think the most potent way actually to kill B cells is the CAR T cell, expressing actually the CAR on the surface of a T cell and thereby combining antigen recognition function with effector function, depleting B cells in a very sustained way. I will show you one slide why CAR T cells are so potent in depleting B cells. And CAR T cells are also quite young, right? It's about 10 years ago that Emily Whitehead was treated at the age of 6 with acute lymphoblastic leukemia. And she actually died 2 times almost, once because of the leukemia, and actually CAR T cells rescued her from this terrible disease in a sustained way. And you can see the yearly photos which are made from Emily Whitehead, and she's a completely healthy young lady, indicating that you can cure a patient, right? And I think we should also, in rheumatology and in other fields of inflammatory medicine, we should we should actually learn from oncology that this is possible. And the second problem of Emily Whitehead is when she received the cells, she got a terrible cytokine release syndrome. And it was only by chance that that actually tocilizumab, the IL-6 receptor antibody, was used with her, and it rescued her life. And it was by chance, because Carl June did know about rheumatoid arthritis, did know about the new therapies in rheumatoid arthritis, IL-6 inhibition, and IL-6 was the key cytokine in the cytokine release syndrome, which popped up, and therefore actually she was rescued by tocilizumab infusion, which is a standard of care of CAR T-cell therapy until now. Now, CAR T-cells are actually very potent cells. They are binding to the target cell and killing the target cell. And you can see that here in this short video showing the apoptotic death of a tumor cell, which is in greenish, bluish, and upon contact of the CAR T-cells. And this is possible due to the CAR, which is actually a transmembrane protein expressed on the T-cell, which has a single-chain variable fragment of the immunoglobulin, allowing antigen binding. And when the antigen is bound, the intracellular part of the CAR is activated, which consists of a co-stimulatory domain and the 3D zeta chain. And these two signals are absolutely required to activate the T-cell. The T-cell always needs two signals: a T-cell receptor activation and a co-stimulation. And the CAR actually has in one molecule both, which is a pretty interesting story, right? I mean, when the antigen is seen, the CAR is activated and can basically do the whole job. So CARs have certain properties which are different from other conventional drug therapies. The first is they proliferate in vivo, which is also named as to be a living drug. So basically, when the CARs are infused, they recognize the cell, the target cell, and they are not only activated, they proliferate. Yeah, like a T cell is doing when the antigen is recognized, it's proliferating. And the CAR T cell can proliferate 1,000 times in vivo. Then they do serial killing. So one CAR T cell can kill about more than 1,000 target cells in vivo. And finally, the third important feature of a CAR T cell is that they have an extremely good tissue penetration, because they have, as T cells, they can go to all parts in the body, including the central nervous system, making the extremely powerful tools to eradicate the entire B cell population. So, and these features were the reason why in 2021, we thought that might be worth to use in a patient with autoimmune disease. And in 2021, which was in March, we were in the midst of the corona pandemics, and but we had not only corona pandemics a problem. This patient had a completely other problem. She had, as mentioned, she had a very severe lupus, and she had involvement of kidneys, lung, heart, joints, and the skin. And she cycled through basically all available drugs, which are potent drugs, as you may know. Cyclophosphamide, for instance, is not a drug you are always so happy with a young lady, especially in higher doses. And also she had B-cell depletion with rituximab. And despite all this, she had a very active lupus, multi-organ disease, and this is reflected, for instance, by very high double-stranded DNA antibodies and a proteinuria based on a glomerulonephritis WHO4, which is actually a quite dangerous disease in her kidneys. Now, the concept of CAR T-cell therapy, which is most widely used, is a so-called autologous CAR T-cell therapy. That starts with a leukapheresis, where you basically take the leukocytes from the patient. Then you enrich for T-cells. That's a step where you negatively select the T-cells by antibodies against B-cells, monocytes, and NK cells, for instance. So you end up with a quite pure T-cell population. You need about or maybe you don't need it, but we started with a population about 100 million T cells, and then these 100 million T cells are then transfected with a lentivirus encoding for the CAR, and about 1/3 of these T cells then become CAR T cells, meaning they express the CAR on the surface. And then you proliferate this population or you expand this population with a cytokine cocktail. And this is a substantial expansion. It's 50-fold expansion. So you end up in more than 1 billion CAR T cells. And you only take a tiny amount of these cells and you infuse them in a very unspectacular way. It's a 10 minutes infusion into the patient, and then they do their job and kill the B cells. I should also say that the patient receives a so-called conditioning regimen with cyclophosphamide and fludarabine. This is a rather low-level immunosuppressive regimen, which allows basically to reduce the hematopoietic cell numbers and allows a better proliferation of the CAR T cells because they compete. There's less competition for the cytokines. You call it also homeostatic proliferation. So we were very nervous when we did this the first time, but no major toxicity came. Why we were nervous? Because we thought, well, using cells, T cells from an autoimmune patient, expand them and give them back would actually could worsen the disease. But this didn't happen, and we had no major toxicity, also no cytokine release syndrome. Instead, we had a massive proliferation of the CAR T cells in vivo, so the living drug concept. And you can see that here illustrated by a very low fraction of T cells being CAR T cells at day 3. And then every third T cell in the blood circulating is a CAR T cell after only 10 days. So you can see there's a lot happening in the patient. And lupus actually broke apart in this patient. You can see that here with the B cell are a flat line, the double-stranded DNA antibody seroconverted. The red vertical line is the infusion of the CAR T cell. Then the complement factor C3 normalized, and also the proteinuria went away. So this was very eye-opening, but the most eye-opening piece in this story was the fact that she's still healthy with this single infusion. And when we infused her with the CAR T cells, we stopped all her immunosuppression, even before when she got the apheresis. And she was also glucocorticoid-free since the infusion of the CAR T cells, and she's now 4 years completely healthy. And whether she's healthy, we don't know, but at least she has nothing what concerns us. And we will see, this is now 4 years, that's an old slide. And you can see here 1,500 days follow-up, more or less. You can see one interesting part that the B cell, they came back, which means that the CAR T cells are not anymore there, or at least not functional, because these B cells express CD19, which is the target of the CAR, and despite that, they come and they stay, and they are stable. But what is very interesting, the double-stranded DNA antibodies never came back. So that's we call that as an immune reset, because she is in continuous drug-free remission. And this prompted us and others to test CAR T cell therapy in patients with autoimmune diseases, particularly severe forms, also myositis and systemic sclerosis. You can see here some of the patients. They are usually young or mid-agers, mostly female, but also some men are affected by these diseases. And bottom line, you can see here that among the 15 patients, we had only one relapse. This was actually a relapse after 9 months, not 15 months. It was in patient with myositis. I will refer to this a little later. But what you see here, that these patients, and that's also a little bit old figure now, but at this time of I draw this table, many patients had 2 years follow-up, and all of them had 1 year follow-up, and they were off immunosuppressive drug therapy. So when you look at these patients, these responses we felt were extremely deep. So this is an example of a young mother. She developed lupus in the pregnancy, gave birth to a son, a healthy son with cesarean section, and she had an intractable lupus after the pregnancy. Lupus didn't get better, no drugs worked, and you can see here this massive rash and also the edema due to nephritis. And this was her after the treatment. And you can see that it's actually eye-opening what you can do in some patients with this kind of therapy. And this is just illustrating this deep remission with normalization of disease activity, double-stranded DNA antibody, complement levels, and proteinuria in 8 patients we treated at this time in our center. Then we also moved, as mentioned, to myositis patient. The first myositis patient was a man completely bedridden with 6,000 CK, as you see here, and this actually dropped to normal levels. And this was the MRI and showing actually massive myositis in the hamstrings, clearing up, which was actually following the CK decline, that the resolution of the myositis. And some of these patients, as mentioned, have a very substantial interstitial lung disease. And we use now regularly a so-called fibroblast activation protein PET, which we borrowed from oncology, because the oncologists were interested in tumor responses to stromal responses to the tumor. And FAP, fibroblast activation protein, is exclusively expressed in the fibroblasts, and you can measure actually fibroblast activation in vivo and stage it in a whole body scan. And you can see this very impressively here. Both lungs show a massive fibroblast activation in a myositis patient, and you clear this almost completely with a CAR T-cell therapy. The same is true for systemic sclerosis, where this process is at the hallmark of the disease. And here is an example of combined heart-lung involvement, which is almost completely cleared, especially the heart-lung involvement is still somehow there, not completely cleared, but at least improved. And as you know, some of you know, heart involvement in systemic sclerosis has a very poor prognosis because actually of conduction problems due to fibrosis and with a high mortality rate. In systemic sclerosis, we also now do serious skin biopsies to understand what is happening in the tissue. And this is one example here, which is not published yet, where we did actually before and then 3, 6, and 12 months after CAR T-cell therapy skin biopsies. And what is quite interesting, that in the normal papillary structure of the skin, which is important for mechanical stability, is due to fibrosis massively impaired. You don't see the normal papillary structure like here in the baseline situation, and you get to some extent a rebuilding of the skin and the reappearance of some papillary structure, which is quite interesting. And I think there is now more research necessary to understand to what extent such therapies can restore tissue homeostasis in certain organs. And of course, biopsy work is necessary for this. So for the people living here, mountains are very important, and mountains always go along with valleys. And in fact, what a CAR T-cell therapy is doing is creating a deep, narrow valley. This is indicated here. This is this valley, and this is basically showing the B-cell load. The B-cell load is here, let's say normal, and after CAR T-cell therapy, we probably come to a stage where you have no B-cells in the patient, and then you recover the B-cells rather fast, as you have seen. After about 90 days, the B-cells come back. So what you do with the eradication of all the B-cells except the plasma cells, which do not express CD19, you probably come up with a kind of a resetted B-cell system, which lacks the autoimmunity and the autoimmune B memory cells. Now, how does it look, this deep valley? You can see that here. Each line is a patient. You can see here 800 days follow-up, and here the first 10 days. So the B-cells disappear very fast. And then this is the deep valley here. And then you can see that the B-cells come back after 50 to 150 days. That's a little bit different with individual with the patient, but you don't create actually a state of a permanent B-cell absence in the patient, which is, I think, good, because that would impair you in a sustained way to build up normal vaccination responses. And what are these B-cells? So these B-cells, I always say these B-cells are baby B-cells, because almost all of them are naive. So there are 3 time points here: baseline, early reconstitution, which is about when the B-cells come back after 3-4 months after the therapy, and then established reconstitution, which is about a year after the CAR T-cell therapy. And you can see that almost all these B cells are naive and the memory B cells are very low. So this is a split axis here. And you see they are in the 2-4%. And there is only a little recovery of the memory compartment. And this is resembling a little bit like the building up the B cell memory in a child. So it takes time till the B cell memory is built up. You can see a complete absence of the pathologic plasmablast in lupus patients and of the so-called double negative B cells, which are also called ABC cells or activated memory B cells. We'll skip that. Now, the really interesting story, I mean, we always were struggling to say, do we really see a deep B cell depletion? And then we decided we follow now each patient with a lymph node biopsy at the onset and at the follow-up. And this is data, the initial data we published on that. You can see here a lymph node biopsy, which is ultrasound-guided lymph node biopsy we do by ourselves of the inguinal lymph node. And you can see here a CD19, CD20 staining. And you see follicular structures here. This is before CAR T-cell therapy. And here you can see a complete eradication of the entire B-cell population in the lymph node. And this is rituximab, zero circulating B cells, full of B cells, and maintained lymphoid follicles in the tissue. And furthermore, what was also very eye-opening, I should say, is that you lose the follicular dendritic cells. The follicular dendritic cells are important to keep the follicle and give signals like lymphotoxin beta to B cells. So the B cells, obviously the follicular dendritic cells really need the B cells to be there. After CAR T-cell therapy, all the follicular dendritic cells, which you see here, are completely abandoned or gone. And in rituximab-treated patients, you can see that they are very well preserved. So what happens is probably that you lose actually also antigen presentation function in the lymph node for some time, and also indirectly T follicular helper cells, which are in the follicle, are also completely eradicated after CAR T-cell therapy. And that's probably important to achieve this immune reset because when we look at the T-cell compartment, you can always say, well, the lupus is a genetically driven disease. You have pathologic T cells, you have pathologic B cells. So when you take away the B cells, why doesn't the disease come back immediately? But this is not the case, as I have shown you. And I think one of the reasons is that you normalize actually also other cells like the pathologic T cell compartment. And when you do single cell RNA sequencing of T cells before and after CAR T cell therapy, you can see that what is shifted to the left means that this is less expressed in the T cell after CAR T cell therapy. And when I look at these genes, many of them are type 1 interferon genes. And type 1 interferon is a critical factor for immune activation in autoimmune disease. And it seems that this pathologically activated type 1 interferon response is also normalized after CAR T cell therapy. Now, for those of you not so familiar with the B cell lineage, B cells are starting from bone marrow precursors. In the bone marrow, they acquire the pre-B cell receptor and then the B cell receptor. And then they emigrate into the secondary lymphatic organs, spleen and lymph nodes, and develop into memory B cells or plasmablasts. And a fraction of these cells actually is going back into the bone marrow and build up the long-term immune memory, vaccination memory in the bone marrow by these long-lived plasma cells. Now, when you target CD19, you are quite broad, right? You eradicate also these early precursors, and you also directly kill the plasmablast, but you don't touch the plasma cells. And when you want to touch the plasma cells, like in multiple myeloma, you have to, for instance, target BCMA, which is an antigen also expressed on the plasma cells. So what does it mean for this therapy? As you know, CD19 is the target of the CAR T cell. And since CD19 is not expressed on the plasma cell, it is obviously possible to maintain vaccination responses. And these are the vaccination responses we tested: measles, mumps, rubella, tetanus, pneumococci, and SARS-CoV-2. And you can see that they are not going away like the autoantibodies, right? They are pretty stable. Some of them go a bit down, but they are still measurable. And what is also interesting, when you vaccinate these patients, when the B cells come back, you see a humoral response against the vaccination. So that means that you probably have a normal B cell system back to some extent, and the memory comes back later, right? Depending on infection and certain vaccinations. Now, there are some approaches, and this is a study from China, where you combine CD19 and BCMA CAR T targeting, CAR T cell based CD19 and BCMA targeting. So this is also resulting in a naive population of B cells. What happens, however, is the immunoglobulins go down, and you need supplementation of the immunoglobulins. But what you also do, you also eradicate antibodies which are usually resistant to CD19 CAR T cell therapy, because they are very much anchored in the plasma cell compartment. This is not for double-stranded DNA. Double-stranded DNA goes down both in BCMA and CAR T cell therapy and CD19 CAR T cell therapy. But for instance, raw SSA antibodies are usually very stable with CD19 CAR T cell therapy, and they are then also touched by the BCMA approach. So we will see whether this is actually important for some patients where the autoimmune response is very much anchored in the plasma cell compartment. Now, how about tolerability? I mentioned the cytokine release syndrome. Cytokine release syndrome starts because the T cell is activated when it meets the target cell, usually a cancer cell or any other B cell. And together with monocytes, this leads to a production of interleukin-6, 1, and nitric oxide, leading to it can result in a shock-like situation. This is very, well, it's not super frequent, but it can happen in cancer patient. And one of the critical factors for a severe cytokine release syndrome is a high burden of tumor cells. So this means that there is a very active activation of the CAR T cells, because there are many target cells, and that actually increases the risk of a cytokine release syndrome. In autoimmune patients, we don't have a malignant B cells, and the burden of or the load of B cells in the body is much lower than in cancer, and therefore the risk of cytokine release syndrome, as far as we know so far, seems to be low. For instance, this is our study we did with 15 patients, and you can see here the body temperature and the blood pressure in the first 10 days in the hospital. And you can see that there is a fever development, usually between 1 and 3 days, which is a so-called cytokine release syndrome grade 1. But not much actually hemodynamic effects of this fever. So this is a usual finding after CAR T cell therapy, but can be managed very well, either by antiphlogistic or antipyretic drugs, or by a single shot of tocilizumab. This is usually then controlled. So here you can see 40 patients we have treated in our center, and the colors show actually a higher grade cytokine release or higher grade cytokine release syndrome or neurotoxicity. The red and the brown show grade 3 and grade 4 events, and you cannot see a single one. So ICANS is, we never saw an ICANS, but ICANS have now been described in CAR T cell therapy in autoimmune disease. So it's not zero. And at the moment, nobody knows why some probably products have occasionally an ICANS event, neurotoxicity. Cytokine release syndrome occurs frequently as grade 1, which is here in yellow, and sometimes as grade 2, but we also had no higher grade cytokine release syndrome. That doesn't mean that they don't occur, but at least they are not seem to be very frequent. And when you observe these patients in the long run, infection rate seems to be very low. And I think that's because they have no immunosuppression and they have a constituted B cell system. What you see, and this is here to read it, it's actually, these are the patient numbers, and this is less than 3 months and up to more than 1 year. You see most of these events are upper respiratory tract infections like COVID or other triggers. Some have herpes simplex and herpes zoster reactivation. There were 2, I think, herpes zoster. So that happens, and that's probably also related to this time-limited decrease of the T cells after the conditioning, probably. We don't know. So one has to be vigilant on infections, but at the moment we don't see a strong signal also in the long run. Now, this situation, the efficacy and the safety has led to a burst in CAR T-cell studies all over the world. This is an old picture from February 2022. It's now definitely higher. And you can see here 40 studies mentioned. Most of it is lupus, but actually there is now myasthenia, then multiple sclerosis and other diseases included. You are doing here a program on stiff person syndrome, which is very interesting and probably a very interesting indication for CAR T-cell therapy. Children are also affected sometimes by very severe autoimmune diseases. I show you 2 patients with lupus. Of course, with children, it's always, or teenagers, always a situation that probably the genetic load is more important. So we will see how they do. But the first data look very good. This is a 15-year-old girl with a very severe systemic lupus, heavy pre-treatment, as you see here. And during the production of the CAR T cells, she came into hemodialysis because she had a kidney failure due to glomerulonephritis. And we treated her during the hemodialysis, and she's now more than 1 year in remission. She has, you see the kidney function normalized. She has now a creatinine of 1.0 or so, and also lupus disease activity and double-stranded DNA antibody disappeared. And this is also flanked by new data also from the Italian colleagues showing a resolution of glomerulonephritis. As you see here, the IgG deposits and the complement deposits in the follow-up kidney biopsy disappeared. And I heard also that in Seattle, there is actually a clinical trial starting with pediatric autoimmune patient. And I think for them, I mean, for this young girl, I just say she was at the right time, at the right spot, because she would be lifelong on dialysis or on a immunosuppression due to kidney transplantation, and she's now completely fine, right? I mean, I think that's for this indication extremely interesting. Now, there are other examples for CAR T-cell therapy, very little data so far in rheumatoid arthritis. Now, I think a couple of cases have been published with good success. This is a patient we have done together with the neurologist because this was a patient with myasthenia and rheumatoid arthritis. And you can see here that we achieved a remission, and even more importantly, the anti-cytokine protein antibodies disappeared in this patient. So we can seroconvert, obviously, a patient with autoimmune seropositive rheumatoid arthritis. But at the moment, the data are very limited in rheumatoid arthritis, but I think more will come in the future. And I leave this at the end, the last 5 minutes, to discuss a little bit the possibility that CAR T cells can go into the brain. They are not limited to the blood-brain barrier. And some autoimmune diseases are happening in the brain, like multiple sclerosis, which can be discussed because there's a strong peripheral component of multiple sclerosis. Otherwise, one can probably not explain the good effect of rituximab therapy or basically other B-cell depleting antibodies. But there are also autoimmune encephalitis. But sometimes there is also a massive affection of the central nervous system in diseases like lupus. And I should say that these patients are always excluded from clinical trials, right? And the evidence how we should treat these patients is very, very limited. So I will show you that we decided last year to treat this patient with, it was our first neuro-lupus patient, a 20-year-old man who was bedridden due to a transverse myelitis, cycled through cyclophosphamide, methotrexate, rituximab, plasmapheresis, glucocorticoids, hydroxychloroquine, and had lesions in the brain here and also very strong lesions in the spinal cord. He had a hyperreflexia in the patellar tendon and also a positive Babinski showing very impressively the massive central nervous system affection. He was completely B-cell depleted in the periphery, but he had still B-cells in the central nervous system, in the liquor puncture, cerebrospinal fluid puncture. And we treated him under dexamethasone prophylaxis. And first, what was interesting that these lesions in the brain disappeared, and they also there was a regression to some extent in the spinal cord. And after about 3-4 weeks, he could sit up from the lying position and could also move his legs much better. And after a rehabilitation, he could walk for the first time since, I think, 1 year in the bed. He's still not completely walking fine, but he can walk. And that's a big difference if you are in the bed and if you can walk as when you are 20 years. And so I think this is also a new indication for cellular therapy. Now, this is a very young field, right? And I think there are some challenges. I think patient selection is pretty important, right? When somebody has a very advanced disease with a lot of tissue damage, it's not reversible. And I think the patient selection is a very critical piece of the success or failure of this therapy. Then what is also important, we still don't know what is the perfect target. Most evidence comes from CD19, but also BCMA, as mentioned, to target plasma cells might be very important. We also do not really know how much lymphodepletion is necessary. We actually made a few patients with half lymphodepletion, and they worked quite well. We think we still need lymphodepletion to allow a substantial expansion of the CAR T cells, and we'll give you an example in a minute. Then I think it's important to stop the drugs. I think it's not good one should be very careful to have T-cell targeted drugs in a total B-cell aplasia that could trigger opportunistic infection, and the toxicity management is very well established. And finally, monitoring is rather easy because you can monitor CAR T cells, you can monitor B cells, you can monitor immunoglobulins, you can monitor autoantibodies. So you can really see what you do live and with simple measures. And finally, it's unclear how you treat actually the flares, potential flares. So now flare treatment, I give you one example. I mentioned that one patient with myositis had a flare, and the flare occurred about 9 months after the treatment. The patient was in complete remission, no drugs, but then the myositis came back with an increasing CK. So what we did a very simple approach. We just thawed the cells we had frozen and gave a conditioning regimen and a second shot. And to our surprise, what happened? Nothing, right? So this was the first exposure, very nice expansion of CAR T cell. The second exposure had 0 expansion. What you can also see that there was no B-cell depletion, so there was complete depletion in the first shot. In the second shot, no depletion. And the lymphodepletion worked. You can see both the second and the first shot had a equal lymphodepletion. The patient had no effect at all. The CK increased, and the reason for that actually that it didn't work were T cells recognizing the CAR. So when we gave the CAR, these CAR T cells, they were recognized by preformed T cells and they were immediately killed, and therefore we had no expansion, as you see here. So what we did, we exposed this patient to a BCMA CAR, and you can see the BCMA CAR worked. You see the expansion here, involution, which is usual after 50 days. Then interestingly, we saw a B-cell depletion with the BCMA CAR, which was new because BCMA is considered to be only on plasma cells and plasma blasts, but actually the tiny amounts of BCMA on B cells are sufficient to kill the B cell population, at least for some time, with a recovery thereafter. And you can see the leukocytes went down. You can barely see that because this is, I think, is an axis of 200 days. So this is that's the leukopenia, which was very short, and they come back then. And in this case, the patient is now 6 months in remission. It's rather short. We have to see how she develops, but it shows that you can probably use a different CAR when the patient relapses and achieve remission again. And the question is how sustained this remission will be. So this is my last slide. I think what we see is a growing family of patients. who are probably not anymore patients, right? I struggle sometimes to call some of them patient because they are doing very well. And I think that's also a reconceptualization of what is a patient, because as rheumatologists, we often think a patient is a patient forever, right? But patient is probably not a patient forever. And we have to rethink that. The question is, when we declare them as cured, at least some of the patients may have a very long-standing drug-free remission, as it seems. And I also should say that this is classical academic medicine. It's a very nice cooperation between different disciplines, especially hemato-oncology, immunology, and rheumatology, but also other disciplines are very interesting to cooperate with, for instance, neurology or dermatology or nephrology, or also gastroenterology with autoimmune hepatitis, for instance, where a deep B-cell depletion could actually change the trajectory of the patient. So thank you for your attention.
Dr. Schett, what an incredible talk. And, just paradigm changing to see those pictures and see those images and see people walk. It's just mind blowing. So congratulations on all the science. I'm sure there's many questions. So we'll start over here with Dr. Peschler.
Yeah, so the vaccine antibody responses are preserved, but the anti-DNA and anti-SM go away. Can you elaborate on how you understand those two plasmablast compartments and the response?
Yeah, that's a very interesting new finding, right? Because it was not so clear that the double-stranded DNA antibodies are so much anchored in the plasmablast compartment, whereas other antibodies are much more anchored in the plasma cell compartment. So it supports the notion that double-stranded DNA antibodies, at least in many patients, are probably created by extrafollicular B-cell development and not T-cell dependent follicular development. And they are then short-lived plasmablast rather than being anchored in the long-lived plasma cell compartment. While other antibodies like Rho, SSA, and also, for instance, tetanus antibodies, right? This is much more probably a follicular-driven immune response, and they are much more anchored in the plasma cell compartment. Now, we don't know about the pathogenicity of antibodies because we see sometimes lupus patients who have very long-standing remission, but they still have kept the Rho antibodies, and the Rho antibodies didn't show that they triggered the relapse of the disease. In the patient, we had the patient I mentioned with the relapse, interesting that Jo-1 antibody didn't disappear, right? So whether this is the reason for the relapse, we don't know 100%. We had other patients where the Jo antibody was completely eradicated. So it's even in the same antibody specificity, not 100% sure whether it's plasmablast or plasma cell driven, right? But I think you can disentangle that perfectly with the plasma, with the CAR T cells against CD19, because you can see, for instance, the lymph node, that all the CD19 positive blast cells are disappearing, and the CD19 negative plasma cells, they are still there. Yeah? So it's even in the tissue that you completely disentangle these two compartments. Yeah?
Other questions? All right, Dr. Dreskin, go ahead.
Now it says it's on, and it sounds like it's on. So my initial question was very similar to that, and I'd like to continue on the idea that you have recurrence of B cells without the recurrence of your pathologic B cells suggests some sort of reset in the immune system, perhaps, as opposed to different compartments. One of the things we see with rituximab is not a terrific, but a low-level frequency of hypogammaglobulinemia. Now, you have very small N values, so you may not have seen that yet. Have you seen some patients who become hypogammaglobulinemia? And the other question has to do with your antibody responses. How about to a neoantigen?
So for the first question, the immunoglobulin levels go down to some extent, right? I would say they go down about 1/3, but they don't rarely go below 400 milligram per deciliter, which is the cutoff when we start to replace immunoglobulins. So you see that they are often elevated at the beginning due to autoimmunity, and then they go down. So I think we take away is this plasmablast-based immunoglobulin production, but we don't touch, so most of the immunoglobulins seem to be coming from the long-lived plasma cells in the circulation, and we don't touch them so much. This is very different when you go for a BCMA. With the BCMA, you go down to 100 or so you really deplete the immunoglobulins very well. And neoantigens, we didn't do that because the patients, SARS-CoV-2, the patient had been vaccinated, most of the patient before. Just one patient had not been vaccinated, the first patient, being treated in the beginning of 2021, and she was then vaccinated in the B-cell aplasia, and she developed a T-cell response, but no B-cell response. Yeah? So, and she was later vaccinated, and I think that she also then developed antibodies against SARS-CoV-2. So this is the only example for a neoantigen.
A small price to pay for the resolution of such a disease.
Yeah.
What's the longest remission that you had?
4 years now, yeah.
4 years.
From March 2021 to February now, 2020.
Very nice.
Dr. Schett, how long are these patients in the hospital? You mentioned you bring them in, you condition them, then you apheresis them, and then you give them the CAR T. How long are they staying typically for the treatment?
So we were leaving them 10 days in the hospital. That was with the start of the conditioning plus 10 days post CAR T cell therapy. Yeah? So exactly this was 10 days. No, it was actually 3 days before the infusion, which is the lymphodepletion, and 7 days after the infusion, we released them. So it's 10 days.
10 days.
But you can do it probably shorter because it was also a lot of precaution, right? So basically, I think you can sometimes discharge patients probably after 4 days, right? Some patients had very little problems where you think you could do it or even outpatient, right? But we have not done this so far.
And if you're worried about CRS, it's really very acute, correct? So
it's usually very fast after 1 or 2 days. Yeah.
Sorry, go ahead.
Hi, was it me?
Hi,
I'm a basic scientist. So when I think of lupus, I think of a lot of different cellular and molecular, things that are contributing to pathophysiology. But this kind of suggests that B cells are sufficient for the disease aspect. So how broad do you think this is within the lupus population? And was there anything specific about your patients, either genetic-wise or clinically, that made you pick them so that maybe they're just a subset that would respond?
Yeah, well, I mean, you asked the correct question, and then I think we did not know before that there would be, you could imagine that the genetic background, right? You have an MHC associated disease, you have genes related to phagocytosis, which are defect in lupus, where you cannot clear necrotic or apoptotic material, triggering this interferon response. And all this situation, I mean, this genetic background is still there. And you could say, well, I have basically free DNA around, trigger again a type 1 interferon response, and start to create new autoimmune B cell. But at least this can happen. I think it should not be excluded now, but it doesn't happen that frequently, right? And that points to I think a multi-step procedure to get an autoimmune disease. You need the genes, right? But you need to build up a pathologic T cell response and a pathologic B cell response to go to the full-blown disease. And that's not so easy, right? And if you build up one checkpoint, namely a normal non-autoimmune B cell population, that can be sufficient to maintain the patient disease-free. Yeah? So that's, I think, an interesting gain of knowledge here. I think the reason that it works is also that you influence other cells like the T cells I mentioned with the type 1 interferon response. And we're also working now to look at myeloid cells, if myeloid cells change, for instance, increased net formation in neutrophils, which has been described in lupus. So that's work in progress, and others also work on that. So I think it's a nice model to test concepts. And what we see also, there's a retrograde effect of the B cell compartment on the T cells, right? Which is always considered to be in a row, but it's not like this. Yeah.
One more question over here.
Great. Thanks so much for that talk. 2 questions for you, one of which is related to if you have any insights to this, the long-term safety of CAR T and autoimmune diseases. Certainly, in the oncology population, we worry about, therapy-related myeloid neoplasms, case reports of other T-cell neoplasms.
Yeah.
Curious on your insights if, there's any issues hematologically or potentially moving forward for these patients. The second question I had for you as well is somewhat related. It goes back to lymphodepletion. One question for you is, in these patients, are they previously receiving Cytoxan as any part of their autoimmune therapy? And then do you think, as a part of the conditioning here, the Cytoxan is doing a lot of the heavy lifting and minimizing disease burden prior to CAR T administration?
Yeah, so the second question is, so the average Cytoxan cyclophosphamide dose in the patient has been 7 grams. And the conditioning is only 1 gram. So basically, we think that that's why we also think that the conditioning is not contributing to any clinical effect on the disease activity. Yeah? It's indirectly contributing by a CAR T-cell expansion, because the dose is much lower and much higher doses didn't have a clinical effect. We didn't see actually a lot of difference in Cytoxan exposed and non-exposed individuals with respect to CAR T-cell proliferation and involution or B-cell absence. So this doesn't matter so much, I would say. Then the first question was the T-cell lymphoma. So it's important to know that the T-cell lymphoma rate in a B-cell lymphoma population is 1,000 times higher than in the normal, or 100 times higher. Yeah, it's 100 times higher than in the normal population. Yeah? So there is an intrinsic risk for T-cell lymphoma in a B-cell lymphoma population, and that can be seen that the T-cell lymphoma rate in non-CAR T-cell treated B-cell lymphoma patient is as high as in CAR T-cell treated B-cell lymphoma patients. So there's probably a genetic instability. And another interesting situation is that in some of the cases where the CAR was found in the T-cell lymphoma, this mutation was already found before, the CAR T-cell therapy, and then these T-cells were included in the production process and were then stimulated by the CAR, right? And there's a very nice paper, I think it's in New England or in Nature Medicine, where you can see that actually the therapy worked and suddenly one clone is boosting, and this was the malignant clone. So personally, I think that's not an issue for 2 reasons in autoimmunity. First, the rate of T-cell lymphoma in a non-malignant population is very low. Second, there is no persistence of CAR T-cells in the autoimmune population, because after 6 weeks, they are more or less gone, what we know.
Dr. Schett, thank you very much for a terrific grand rounds.
Yeah.